Hello and welcome to Inside Exercise. I'm Emeritus Professor Glenn McConnell from Victoria University in Australia. Today I'm bringing to you Professor Kristian Thorborg from the University of Copenhagen in Denmark, who also has a 20% appointment at Lund University in Sweden. So his research focuses on looking at, providing an evidence base for physiotherapy practices. So it's very interesting. He has a great track record in this. He's been really questioning practices and finding, some support for some practices, not so much support for others. So it was interesting talking about eccentric exercise and how important that is for injury prevention. But other things like rest, ice, compression, elevation, surprisingly, there's not much evidence for that at all. So we talked about that quite a lot. We also talked about the different sort of modalities that physiotherapists use, the evidence for those or not. Now, I found it really interesting. Indeed, we went like an hour 45 or so. I could have kept talking forever. I think a lot of us have interest in, injured sort of sports people along the way. So I think you'll find this interesting. So stick around. Hi, Kristian. Thanks for coming on. How are you?
Thank you very much, Glenn. Yes, I'm very good. Thank you.
Yeah, I can't help noticing you're maybe a typical Danish man there with your bike stuff drying out in the background. Is that right?
Yeah, that's true. Yeah, and my sports equipment. Yeah.
That's great. I wish it was like that everywhere. And believe me, I'm talking from experience. So as I told you before, I'll be going out there for 6 months in about a month's time to do another research visit. So I can't wait.
Oh, very good. Yeah.
All right. So can we clarify? You're a full professor in Copenhagen, but you're also partly in Lund. Is that in Sweden? Is that right?
Yeah, that's correct. So Lund is very, very close to Copenhagen. So it's like a 40-minute drive. In Australia, that would be like a normal commute, I guess. But I actually have to cross the border, go over the bridge and cross the border to get to Lund. So, but it's a nice drive.
Actually, if people haven't seen it, that's a great show, that mini-series, The Bridge. I know you've got another name for it.
And that's the exact bridge I have to go over. Yeah.
Exactly. So is that Malmo then?
Sorry?
Is that Malmo? Malmo?
Yeah, the bridge goes from Copenhagen to Malmo, and then Lund is the old sort of university city in Sweden, one of the oldest university cities in Sweden, and it's a little bit sort of 20 minutes from Malmo,
wow.
In a very old ancient city. So very nice.
That's quick. Okay, I need to go over there next time. All right. So I'm interested in how you ended up being a professor of physiotherapy, and I'm wondering if there's that many professors of physiotherapy around. Can you give us a bit of an idea? Were you an injured runner or something initially, and you got interested in this, or were you a physio?
I was definitely an athlete, sort of sub-elite level. I used to play a lot of football, so European football, soccer, as you like to call it, not to get mixed up with your kind of football. And definitely also the way in for me, and the reason why I got interested in physiotherapy was in relation to injuries, my own injuries or teammates' injuries and so forth. So I guess that's quite normal. But I would say that we can come back to my professorship. It's not. I would say we don't have a lot of professors in physiotherapy in Denmark. It's much more common, I would say, in Australia. And in the States, and actually I'm not a professor in physiotherapy as such. I'm actually a professor in orthopedic surgery, which is a little bit interesting. But so my work is related to, I work in an orthopedic department, and I work in relation to an arthroscopic center. So they do arthroscopy here, and the collaboration I have with the doctors and with the physios here is that we look whether people need arthroscopy or not, and also if they need arthroscopy, how can we plan the post-surgical rehabilitation. So that's sort of my main position. And then the other thing we do a lot here is we are very, very interested in sports injury prevention. So we've done a lot of research on sports injury prevention. So I guess I have this kind of subtitle that I can use for my professorship, which is that I have a special emphasis on sports and musculoskeletal physiotherapy. So that's sort of that's the emphasis of my professorship. So the reason why it's actually in orthopedic surgery is because at Copenhagen University there is no university degree in physiotherapy. So that, again, that's also quite different from Australia. where you're from. So we are connected to a more sort of broad health education, which is multidisciplinary. So you would have occupational therapists, nurses, physiotherapists, and so forth. And it's a much more multidisciplinary master that we have here, where my teaching is located.
That's interesting because I used to be at the University of Melbourne, and I used to run across the road there, Grattan Street, to teach the physiotherapists across the road. So there was definitely a course there. And now it's like a postgraduate course, and we'd teach the physiology to them. So why don't you tell us your University of Melbourne link?
Yeah, so I went there as well. I went to the School of Physiotherapy at the University of Melbourne. I did my master's in sports, actually, sports physiotherapy. And back then there was different streams. There was the musculoskeletal, and then there was the sports and lots of other streams. But the musculoskeletal was by far the most popular one. I think that probably relates also to job opportunities afterwards. It was more applicable in some ways across working in clinics or in the sports fields or whatever. And I think a lot of the musculoskeletal sports physios, it used to annoy me a little bit because they always said that, they could just apply their musculoskeletal master to athletes. And for me, it was always, that was the reason why I wanted to do sports physiotherapy, because I think that's a very specific sort of trade in itself, and I wanted to specialize in that. So they used to annoy me a little bit with just saying that they could just do the musculoskeletal, and that would be just equivalent to doing a sports physiotherapy.
Well, it's very different, isn't it? Of course.
Yeah.
I'm glad you did that. It's good for the podcast.
Yeah.
You know,
Exactly.
when I first asked you if you wanted to come on, you're like, it's more metabolism and exercise phys. But I don't think we want to be all narrow. We want to think like anyone that's into exercise and the sport is, well, not everyone, but quite a lot of us are going to get injured. And so this is very interesting how to try. And it transcends. We might get around to that as well. It's especially when you think about rehabilitation of musculoskeletal injuries as well, whether they're related to sports or not. I mean, the whole link of not just providing exercises treatment, also in relation to physical activity and metabolic health, as you say, is becoming more and more, I think, integrated now. So from that perspective, I think it's definitely interesting. Yeah, I think this is great having you on, because you'd know Abigail Mackey. She actually suggested you because we talked about injuries when she came on. It's sort of more at the molecular level and things like that. I thought, wow, it'd be great to have you on. So I looked you up and saw your tweets and all that stuff. So I never used to really use Twitter much, but it's pretty important when you're doing this, suss out what people are saying in the area and see what else is coming along. So we're going to talk about, well, I get throughout an abbreviated title, but the full title is sort of the science of sport and musculoskeletal injuries and how to prevent or treat them. And I like that's the science here because there's been a bit of a thing. Actually, my first PhD student, Scott Bradley, who was excellent, he was a physiotherapist. And, his first thing he said, I was like, oh, physio, what are you, how can you doing a PhD in physiology? He wasn't doing a PhD in physiotherapy. And he was like, well, there's not much, evidence base. There's not enough evidence. A lot of people are just doing things they don't really know why. There hasn't really been looked at that much. So, I think that's going to be a theme, I hope, today. That, how much evidence base is there? Is there more? Is there more that needs to be done? And I saw from a couple of your tweets again that you were sort of like, oh, you can't say that. You need the evidence. But I know from the dot points you sent me, there's going to be a balance between evidence versus experience. So that'd be interesting to talk about as well. But so why don't we start off? You're saying you want to talk about different models and challenges in injury prevention. What did you have in mind there?
Yeah, so I think we could maybe if we could start another place first,
okay,
and that's also related to a little bit. The title is before we go into sports injury prevention, and that is so. I'm definitely trained as a physiotherapist, and what you often hear is what's the evidence for physiotherapy? So that's and I think this title also says something about evidence-based physiotherapy. So I think the main thing for me also to make very clear often when I speak to people is that, and this is not, it's not something that I've come up with, and many people have said this before me, but it's still important, is that physiotherapy is a profession. It's not a treatment modality. So whenever people say, what's the evidence for physiotherapy, that's you can't answer that. It's not possible. But physiotherapists work in the field of sports injury prevention, where there is quite a lot of evidence actually for things that work and things that don't work. And we work in relation to rehabilitation, again, some evidence for things that work and not, and we're going to come back to that. So, but that doesn't mean that these modalities has to be provided by a physiotherapist. It could be provided by other people and still be evidence-based care. So I think that's probably one of my sort of main points, is that I'm not, physiotherapy for me is a profession, and we deal with athletes, for instance, that we're going to talk about now, and we try to prevent injuries. We try to treat their injuries, and that is where the evidence is related to. It's not related to physiotherapy. So I know that some of it it's just tradition. We just say, well, I'm going to have physiotherapy, but basically it doesn't really. It's actually nonsense to
I might be a
say
bit
that.
slow here. I'm a bit confused. I'm trying to think, if you go, I'm going to go and see a medical doctor. Yeah. Then that's the profession, but also it should be evidence-based. Yeah. Oh, are you not talking about the evidence-based side of it?
I'm not talking about the evidence-based. I'm just talking about that people talk about physiotherapy as a specific treatment. It's not.
I see what you mean. I'm going to have some physiotherapy done. Yeah,
exactly. And sometimes you will see a doctor refer to physiotherapy. So I mean, and so that's like referring to medicine. It's a field. It's not a specific intervention. So I think that's very important. Also, when we go into the talk, so I'm going to talk about different treatments, different modalities, but not about physiotherapy per se. And then with that said. And just to confuse everyone a little bit, we actually did a large study, and I was part of this study. I was not driving it, but this was a big sort of meta-epidemiology study about randomized trials where we actually tried to find out sort of the evidence for physiotherapy in relation to pain. And we actually had this problem. How do we then define this intervention? So in this study, we just decided, let's just define it as physiotherapy as what physios do. So we put in this large systematic review studies where physiotherapists were doing treatments. So either they call it physiotherapy or it was different treatments provided by physiotherapists. So it was not a very good definition, but we just had to come up with some inclusion criteria. And in this, what was interesting in this study, which had more than 170 trials included in it. And we were looking for whether physiotherapy per se is effective in relation to pain. So quite broad. What we found was that sort of the main thing that actually stood out from that was that the specific modality of therapeutic exercise was actually the one that looked the most promising and most effective in relation to treating pain that was also related to musculoskeletal problems or injuries per se. So I think, I mean, it's a little bit my own fault as well, because in this study we actually used the phrase physiotherapy, but I don't think there is an intervention, and we also say that in the study that there isn't really an intervention called physiotherapy. So this meta study was also about almost to justify, is there even a justification for physiotherapists out there doing their treatments? And it seems so. There was an effect size related to physiotherapy. The interesting part with that is that if you then try to control for placebo, so there's actually a few placebo trials out there, and that might be quite difficult in relation to physiotherapy, because the patient will often know whether they get the treatment or not. It's very, very difficult to blind these types of interventions, like exercise or even different modalities. It's if you have like electrotherapy, you can sometimes shut the machine off, so you can People think they're getting the modality, but they're really not. So there are trials, placebo trials. But the interesting thing was that then when you look at the effect size, which was sort of a moderate effect size of let's call it physiotherapy in relation to musculoskeletal pain injury, if you then looked at and compared it to the placebo trials, the effect size was much lower when you were controlling for placebo, which again means that maybe the effect that we provide as physios is not as specific as we would like it to be. So there might be that a lot of the effect that is provided when we do the treatment is what we call contextual effects, not necessarily related to specific parts of the treatment. We would all like to think that when we include an exercise, this is the reason why the patient is getting better, but there are so many other things related to meeting the patient, and also just spontaneous recovery and regression to the mean that is not necessarily related to the actual treatment being done. So I think that's probably an important point, and that's not related to physiotherapists in particular. That's also related to a lot of other fields like medicine and so forth.
Yeah, well, I guess it also must depend on how good a physiotherapist it is that you're seeing, because I think we've all been to good physiotherapists and not so good. So,
exactly, and I think that's a very good point. So in clinical practice, I think these contextual factors are probably driving a lot of the effect that you would also see in your clinic, and you have to be aware of that. I'm not a big fan of trying to cheat my patients by telling them that they're getting something that they're not, or so it's not about, for me, it's not about sort of trying to promote a placebo, but there's certainly definitely placebo in relation to how you actually meet the patients. And it's not all about your technical competencies as a physiotherapist. It's not all about did you prescribe the right exercise or not. There are many other factors.
It's interesting how well recognized now that placebo is, that if you're having a drug for high blood pressure, for example, it's known that you're going to have a placebo effect. So then the idea is that medicine you're giving them going to be greater than the placebo? You need a proper placebo. I wonder if this is pretty harsh on general medical doctors, but I was going to ask you at one stage, the people that are actually treating people when they're injured are probably, as you mentioned earlier, initially going to be a general practitioner, is what we call them here, like a physician, whatever they call them in America, I always forget. You're straight off, you see them, and then you get referred, hopefully. But quite often I assume people are actually going to have their instructions from the general practitioner, whether maybe they can't afford to see a physiotherapist, or maybe the doctor just says, oh, just do this and that. So I'm wondering if people have compared that would be a bit harder, I guess, to compare outcomes where you've had sort of like a general practitioner, for example, to a physiotherapist, to a sports medicine doctor. It probably gets too hard to
yeah, that's probably that's probably a difficult study to do, but I think it's a good point in terms of, and I think a lot of the things that you will see, or a lot of injuries or things that will happen to people, and you probably have this as well. We all have our different pains and niggles and problems, and a lot of that is usually taken care of by spontaneous recovery. We never even get to go to the doctor often, and it goes away. And then sometimes you go to the doctor or you go to the physio, and again, the majority of what you go with there will probably also be dealt with by time and by simple approaches, just progressively returning back to your activity. So I think that's interesting, because that's also related to our model of care, where we always, when people come to us, and that might be with the GP or the physio, we always want to promote this specific intervention again, where I think for the majority of people who actually seek our help, they probably don't need, for the most part, they probably don't need such a specific intervention. And then you can say that there is a generic sort of approach that will probably help a lot of people. And that's why I also think it might not be that you can show that the physio is far better than the GP or for the majority of the patients. And that's not the point as well. I think the point is that there will then be some patients who don't get better from the generic approach, or from just waiting and seeing, or from just getting a very simple intervention. And then what do you do with those people? And these are the people that also fill up a lot of space in the clinic or in the hospital. I work in an orthopedic care. It's a little bit like the end of the line. They go to orthopedic care here, but then they tried a lot of different things. And their condition is much more chronic than usually than what you would what we experience ourselves, and what never gets to the doctor, or what is easily treated with the doctor or the physio. So it's a different cohort as well, and they are much more difficult to treat. So when you do studies on those, also you need to expect much lower effect sizes. It's if not, you're being unrealistic.
Okay. Right, did you want to talk about, I've got a bunch of things that keep popping in my head, but we had a bit of a structure. So do you want to talk about different models and challenges and injury prevention?
We can go to, because sports injury prevention, I think one of the things that I really enjoy about that as well is that that's probably one of the areas where we have, I would say, some of the larger effect sizes. So it's definitely, especially through an exercise-based approach, there are quite a lot of different types of injuries that you can mitigate or risk mitigate or prevent. A lot of people don't like the word prevent, because it means that to some people that means that you're sort of suggesting that you can prevent everything from happening and all injuries. But it's basically the same as you're reducing the number of injuries, or you're mitigating the risk of getting an injury. So when I say prevention, that is what I'm referring to. So we've done a series of studies in relation to especially European football, or soccer as we can call it, so everyone knows what we're talking about, and shown that especially sort of strength training approaches with very similar one exercise approach, so Nordic hamstring exercise or the Copenhagen adductor, that you can actually reduce injuries by up to 60%, 70% when you're doing the Nordic hamstring exercise compared to usual care. So if you're just following your normal training routine in the club.
Okay.
And with the Copenhagen adductor exercise, again, a one exercise approach, we also showed that you can reduce groin problems with around 40%. So very simple approaches where you have, I would say, quite a high effect size compared to usual care if you just let the clubs do what they would normally do.
Can you just tell us what they are? Because I just think of the hamstring stretch. You whack your leg up on the the table or something, and then the adductor, abductor, sort of on the machine. Want to just tell us exactly what you're talking about there, or? Yeah.
So the Nordic hamstring exercise, both of these exercises, and the reason why we came up with those, are partner-assisted exercises. So the Nordic hamstring exercises, you are on the ground, sitting on your kneeling, and then you have somebody holding your ankles, and then you sort of just lower your body towards the ground and resist it by eccentrically activating your hamstrings. So it's a very aggressive exercise. It's super maximum, so you can't. I mean, you have to resist the fall all the way down.
All the way down.
Yeah.
With both legs at once. Is that right?
Yeah, both legs. And then you push yourself back up, and then you resist the fall. Yeah. So it's a very aggressive exercise.
Make sure people are clear then. So as you said, so you're kneeling with your sort of your butt on your feet, and then you sit up straight, but you're still kneeling, and then you go. Someone's holding your ankles, and you go down, and you've got to resist it, which is eccentric, which people maybe should know that. Which is eccentric is where you're contracting, but your muscles are actually lengthening, which as we know that can do muscle damage.
Or your muscle tendon sort of. Complex is definitely lengthening. We can discuss where it's lengthening, but just
to make sure we're on the same page. So you're doing eccentric. So that's hard because you're resisting resisting gravity, which is kind of the definition of eccentric exercise, until all the way to the ground, and then you come up concentric, which is really hard.
No, you don't come up concentrically. Then you push your way up with your arms.
Yourself up.
Okay. So it's basically only the eccentric part.
Okay. Right, and that's the Nordic hamstring?
That's the Nordic hamstring. I mean, it has many names, but
And that's been shown to reduce hamstring pulls by tears.
So this has been shown to be very effective, around 70% sort of overall injury reduction. And then what is really interesting is if you then look at those with previous hamstring strains, and we know that's the biggest risk factor for getting a hamstring strain is actually if you had it before, then this type of exercise is even more effective. So around 85% reduction. So very, very effective also to try and avoid getting these problems in the future.
So did you say you came up with that, or your colleagues? Or
no. So the Nordic hamstring came from it goes a long way back, but this type of exercise was actually introduced in Iceland, and then they did not a real RCT, but they compared two cohorts, one from Iceland and one from Norway, and had very promising results in the early 2000s. And then in Copenhagen, we did, Jesper Petersen, a doctor here, did his PhD here when I was also a PhD student. So together with him, we did a big RCT and with more than 1,000 players, so 500 in each group. And we had this massive reduction. So that's the study where this comes from.
And is that recognized? I've seen people do it, but to be honest, I don't know. I haven't. Is that recognized? Is everyone doing that around the world? Sort of thing? Is that just a given? Like if you're a sprinter, or if you're an NFL player, or whatever. Does everyone do that?
The exercise actually comes from sprinting. So I think in the fact that sprinters have been using this exercise for many years, and I think, and we've looked a little bit more into the exercise, and I think we now know why it is that has been also interesting to sprinters. So in a lot of sort of athletic sort of basic training, sprinters would usually also do this exercise. And it's definitely, of course, it's building strength, it's building eccentric strength, but what we've can see from our studies as well is that it's actually very, very potent in relation to increasing your rate of force development. And so it's interesting because it's not, you're still just using your own body weight, but as soon as you sort of lowering your body, you have a really sort of a new muscular response to that, trying to resist the fall. So you have a very, very fast sort of neural activation of your muscles initially. And I think that's probably why it's also drives increased rate of force development from this exercise. And that could be why sprinters are very interested in it, because it actually could contribute to making them fast as well, like other types of strength training. So we've seen, So we've seen in footballers that because this exercise was criticized for making people, it was not functional, they said, and so it was in danger of making people slower, was the critique, because it's not a fast exercise. The execution is not fast, so it's not like a high velocity type of exercise, but I would say the activation to resist it has to be very, very fast. So on a neural level, I mean, you have very, very high and fast activation. And we could see it in football players that it was actually the opposite, that if you did this exercise, we could actually see that they were getting faster compared again to just usual care. So it is a very potent exercise. And then your next question is, are people doing it? And that's a very interesting thing, is that the adherence to this type of exercise is very, I would say, it varies a lot. And especially at the elite level, there's been a lot of sort of non-adherence to this type of exercise. They for many reasons didn't like it, especially because it provides a lot of DOMs. Especially if you do
delayed onset muscle, just for people, delayed onset muscle soreness.
Yeah, so if you do this, I wouldn't say wrong in the way that you do too much volume too early, you can really get a lot of DOMs. And there was actually a brilliant study from Australia where they did this, and I think they did 72 reps in the first session, and completely killed these athletes, and they would never do it again.
Well, that's why I was getting DOMs just when you told me about it. I just thought, oh yeah, that would
So when you do the evidence-based sort of program and the protocol out of Copenhagen and Oslo and from Iceland, you're actually just starting by doing 6 reps.
Okay. The other thing I should just make sure people are clear on DOMs. So that was particularly silly, me saying I was getting DOMs, just you saying it. So make sure people are aware, delayed onset muscle soreness. That's when you get sore, like usually 2 days afterwards. If it's really bad, maybe a day after. But yeah, just make sure people know what we're talking about here.
Yeah,
So it's not like you get sore, because some people think, oh, I'm not sore. You know, I can know they go to the gym, that was fine. 2 days later.
Yeah.
All right. So, and just the other thing is just so people know, like, why would that help with sprinting? So I'm assuming it's as your leg goes forward, the lower leg is racing forward, and your hamstrings have to stop your lower leg, and eccentrically. Yeah.
So that's and that was the interesting part, was that when we when we looked at the sprinting, we also looked at different. So it was actually, we looked at 30 meter, 20 meter, and 10 meter. And the interesting, 5, 10, and 30 meter. And so the hypothesis was also that, I think, especially in relation to what you just said, is that especially the 30 meter would probably be very potent in relation to that, because it's all about getting your leg, as you say, back on the ground, and be able to sort of maintain top speed. But what we saw was actually, in the footballers, it was the opposite. It was actually the 5 and 10 meter acceleration where we saw the difference. So again, that it seems to suggest that it might be more related to rate of force development than the actual maybe increasing your eccentric strength per se. That was a little bit interesting to us, and definitely a surprise. And it's been repeated now by a few groups. So you can see that it's actually the initial the acceleration phase where it seems that it's effective.
Okay. And is that reducing injuries or actually going faster? You know, it's reducing injuries, you're saying, no?
So this is, I mean, this is a good question, because definitely we can also see from some of our sciences that one of a risk profile for getting injuries is being faster. So faster injuries are probably more prone to get this type of injury. So is it so? So what happens when you then, if you make them faster with an exercise, are you also increasing their risk? But so with this exercise, what we see from the RCTs in relation to injury risk, it looks like the injury risk is going down. When we look separately in studies more on the mechanism of performance, it looks like the performance goes up. So from that perspective, it's a really interesting exercise, and it looks like it's sort of working positively at both ends.
That's interesting. It makes me think of when you have distance running, you think, oh, this person's getting really hot because they didn't drink enough. And it's like, no, often the person who gets the hottest is the one that's going the fastest, because they're producing the most heat. Right. So what about, was it the Copenhagen abductor?
Adductor. Yeah, so that's also
actually, can we tell people abduction, just to make sure everyone's on the right page here?
Yeah.
Can we just say what that is?
Yeah. So adduction is when you sort of move your leg from towards sort of the midline. Yeah. And abduction is when you move your leg sort of away from the midline. Yeah. And so again, so the idea with these partner exercises was that you will be able to do it on the field and actually try to increase adherence by not making it too complicated by using different equipment or making it only accessible to people who had access to some specific training or whatever. So again, the idea was, so here you are actually lifting people up, you're holding them below their knee and their ankle, and they're supporting. So they're on their side and they're supporting on the elbow and on the other leg. So they're in like this scissor position where they start from, and then they have to lift their body up by, again, adducting their legs. So they lift their upper body up towards that person holding their leg. Does that make sense? So they're like this on the side, and then so this is their legs on the side. And then they're coming up with the leg, and they're lifting their whole body up as they come up.
Okay, all right. So people need to watch on YouTube if they want to see how that looks.
Yeah, exactly. But so this starts as a concentric movement. They lift their body up, but then they have to they stay up there, and then they have to eccentrically again lower their leg down. So they actually have to eccentrically on the top leg where the partner is holding them, they have to again eccentrically control the movement again. So this is more like a traditional strength training exercise where you have a concentric phase, an isometric phase, and an eccentric phase.
Okay. And that one's been shown to reduce what, a groin injury?
So that showed that reduced groin problems problems, again in a large RCT with around 40%. And the interesting thing with this exercise, I think, is that we looked a little bit on risk factors here as well. So one thing is when obviously the main point is to reduce number of injuries. But sometimes, and you would know this from physiology, you also look at these surrogate measures that are related to risk reduction. So eccentric strength in the adductors is actually a risk factor for. So if you're weaker in your adductors, you're at increased risk of getting groin problems, groin pain, groin injuries.
Weaker eccentrically.
Yeah.
Okay.
Yeah, eccentrically. And also isometrically, there are a few studies showing. So both eccentrically and isometrically, those who are weaker seem to be at increased risk of getting groin problems. So we've used this surrogate measure also to try and see what happens if you increase the volume of doing this exercise. And can you do, so one thing is, so when we did the exercise again in the beginning and in this, and when we came up with it, we did quite a large dose. And you know this from physiology, you want to make sure that you get an effect. So sometimes, often you probably get quite a high dose. Also, sometimes a dose that might not be that realistic in a clinical setting, just to make sure that you have an adaptation. So this was where we were coming from. So when we did the initial studies and looked at eccentric strength, we would have in the area of sort of up to around 1,000 repetitions over a period of 8 weeks. So when you, for each repetition, you both work the upper leg and the lower leg. So when you change people around, it's 2 repetitions per repetition, really per leg. So so we were doing quite a lot of repetitions in the beginning, and also saw a massive strength increase eccentrically. Up to like 30%, and this is definitely not structural in 8 weeks. That everything that you change here. Again, I think this is also neural a lot, and especially there's a huge learning effect with eccentric contractions as well. So then we applied it clinically, or in the intervention study we saw an effect, but then everyone said, oh, but is it too aggressive? Could you do less and have the same effect? So that's why we've been looking at whether how little can you actually get away with and still have an effect, at least at the eccentric strength level. And we published a study on sort of the dose response relationship of that. And it looks like that you can definitely do too little. So if you're in the area of around 200 repetitions, over an 8-week course, 6 to 8 week time course, then you won't see an increase in eccentric strength. But if you we could simply plot all the studies, and if you go up to 400, 500 repetitions, you will see a 10% increase. If you go all the way up to 1,000, you are more in the area of these 20 to 30% increase. And then it looks like also that there is a ceiling up there, that it's not like if you then go to 2,000, then you have a 60%. I mean, there's probably a ceiling around. Yeah.
So I'm interested in how you said with the adductor, so that's adding, so your legs are kind of out wide and then bring it towards the midline. You said, eccentric is effective and isometric, so it's when it's not shortening, is effective. But those machines that most of us are familiar with, you sit on there, the hydraulic, and you're going concentric out, which is abduction, and then concentric in for the adduction. Those machines. So they're only doing concentric. Are you thinking that they wouldn't be that effective? You need the eccentric or the isometric load.
I would definitely think that the most important thing for muscle tendon injury prevention is that you get, I think it's important that you get that eccentric part. And I definitely think that you also, if you're talking about a balance in an exercise, I think the eccentric stimuli and the isometric stimuli, I think, needs to be a lot bigger than if there's also concentric stimuli. I think if you have too much of a concentric stimuli, that won't transfer into what the muscles are actually doing.
Unless you're cycling, I guess.
Yeah, exactly. But so we've only looked at mainly in football, sprinting type, change of direction.
Sport.
So you're absolutely right. It depends on the sport and the specificity of the sport.
That's what I wanted to ask you. So I've often wondered about that, because you touched on it, because you know how you said with your Nordic hamstring, so lowering yourself. You said some people said, oh, it's not fast enough to be realistic or whatever. I've often wondered about that, because it's the same with the classic, I was an ex-runner, so I always had calf problems and sometimes hamstring, but with your calf problems, your Achilles problems, they often have you doing like calf raises, and it's slow. My sports med doctor would always say, like, 2 seconds up, 2 seconds down, so concentric and then eccentric. And you say, but that's nothing like, when you're running, it's so much. So you're saying you need the eccentric loading, but it doesn't have to be fast. It's good if it's sort of specific to your movement.
I think it's more, specificity are many things, and this is your field more than mine. But I think if you think about running as well, it's not that you have a lot of range going through. You don't have the range that you do when you're standing on doing your calf exercise as well. So I think it's probably more important to get closer to the actual load whenever you hit the ground with each step. Then so I think if the load is high enough, I think that's more important. If the contractions are closer to what it looks like when you actually hit the ground, and then you can always discuss about the speed of the contraction, of course. And this is also why I think we've shown in studies that strength training and rather slow strength training, I would say, compared to athletic movements, is quite effective. But I think if you want to be more specific, you need to move from strength training into plyometrics. So if you want to sort of build that even more specificity into it, you need to think about plyometrics. But plyometrics can be a very tough place to start, both if you have an injury, but also if you're dealing with athletes who are performing during the week. If you're afraid of strength training and DOMs, you should be even more afraid of plyometrics.
So make sure people are clear again that plyometrics is sort of bouncing. So if you're doing the calf raises and you're like sort of bouncing at the bottom, and that's what you mean by the plyometrics. Sort of dynamic movements.
So you have this coupling. You have this coupling of going from eccentric to concentric a lot faster. So that of course mimics more athletic performance, but again, it's also very, very aggressive on your muscle tendinous complex, which is the whole point as well. So
I guess that makes sense, because if someone's, I always think of running, sorry, but if someone starts off running, you don't usually tell them, I'll go and do intervals straight away. So you build a base, and then you start doing those higher. So you build your base. If you have dodgy calves, or Achilles, you do your slow, concentric up, eccentric down before you start doing the plyometric stuff.
And there will be a transition phase where you can always argue when is it relevant to sort of be more closer to the actual function that you're going to do, and when is strength training still relevant to do. And I think so. For us, it's always a transition. At some point, you do a transition from strength training. You try to make it as specific as you can, and then you go into the actual, as you say, function, and try to build a base where it's more specific to the type of running, change of direction, kicking, or whatever it is that these athletes need to do. And that this is also some of the other studies we've been involved with. There is especially a FIFA 11 Plus program, which has been used in football a lot. And basically, if you look at that program, it has these features in it. So there's like a general warm up there. There's a little bit about activation, a little bit about motor control, but then there is a specific conditioning module where you're doing these kind of exercises. So the Copenhagen adductor, you're doing Nordic hamstring, you're doing a plank, you're doing also for the abductor. So what is actually, I would consider strength training. And then you move into also more plyometric type of exercises like bounding, different kind of jumping, landing, changing direction, and so forth. And that program is also very, very effective for footballers. And especially, I think there are a few studies also suggesting that it's actually that the plyometric part, especially for athletes, is very, very important also to reduce injuries.
It's interesting you say bounding, because I mentioned cycling, which people may or may not know is purely concentric. You're just always shortening the muscles. You're not doing eccentric. But I remember Lance Armstrong, and sometimes people, ooh, Lance Armstrong. But I remember seeing Lance Armstrong doing these bounding, like back and forth. He had this like I don't know, something was in the middle, and he was jumping from side to side over it, like one-legged or something. It was like, wow. So obviously, again, there's some sort of non-specific movements that are giving you strength, and who knows, reducing your chance of injury and just making you stronger.
Yeah, I wouldn't know how it transfers to cycling, and I would also say cycling is probably one of the sports I work the least with.
The least,
like almost nothing.
Well, it's very different, isn't it? The injuries and things are very different to running. Okay,
absolutely.
so one thing we talked about as well with your top points was strengthening versus stretching. So I guess we haven't talked about stretching except me putting my silly leg up on the table to stretch my hamstrings, which probably does nothing. So what do you think about that with prevention of injury stretching? It's been a little bit controversial, I guess.
It's been controversial because it came up. I would say it was a very, very big thing, especially in the 80s. It came up and was sort of the thing to do for sports injury prevention. And it's interesting sometimes to go back and try to understand where things are coming from. And I'm not sure that this explains everything, but one of the really pioneer studies from the 80s was an RCT from Sweden. It was the first RCT by Professor Jan Ekström, was also in football, and they were looking at actually like a multimodal approach. So they were looking at how can we prevent injuries in football. And they were not looking at one modality. They were not looking at strengthening or stretching alone. They were looking at let's try to see if we do a proper warm-up. Let's try to see if we say to these players, don't go and shoot at the goal before you're warmed up, which sounds really stupid that people would do that, but that was what people were doing at the time. Let's try to do some flexibility exercises, and stretching was in there. Let's give them shin pads, scarves, so they're protected more, and so forth. And that study showed a massive injury reduction as well. So compared to the usual care at that time, you could really reduce injuries a lot. I think it was around 60, 70% again. I can't remember 100%. But then Jan Ekström at the same time also did quite a few studies on stretching and showing that you could, if you did stretching and massage and stuff like that, you could increase range of motion. And I guess the combination of those studies, which were very, very important at the time, sort of suddenly made the conclusion was made that stretching is the important thing, is to prevent injuries. At least in football, you have to stretch.
So when was this roughly?
So these studies were from 83, 84, and Jan Ekström has to be commended because these were the first RCTs that we know of in injury prevention. So this was pioneer stuff. What you have to remember is that they were multimodal, so he could not say anything about what was the active ingredients. Was it everything combined, or was it that they were not kicking on goal now and so forth? But stretching was sort of lifted up there as the most important thing, also because it was probably easy to do, and it became very much in favor, and everyone started stretching. And so back to your question, does stretching work? I would say definitely for increasing range of motion, stretching works in the short time. You can increase your range of motion very quickly, and probably it's related to stretch tolerance. You've been to Copenhagen, you know Peter Magnussen as well. This is from Michael Kjær's group and his group, and that they showed that it's probably not related to the material properties of the muscle and tendon, but more related to sort of the stretch tolerance. So probably some central derived effect it's not a lasting effect. So that means that if you're an athlete that needs increased range of motion in your sport, it makes a lot of sense to be stretching, and probably also why you will see people who needs increased range of motion that they do a lot of stretching before they do the performance. Whereas if you are a sprinter, for instance, and you need to performance where you need to run faster, of course, then stretching actually looks a little bit detrimental. Like this actually decreases your sprint performance if you do passive stretching, that is. Also some nice studies from Australia have shown that. So again, you need to, it's not that stretching is not effective, but you need to consider carefully when you apply it. And then in relation to injuries, I think the evidence is definitely not there on preventing injuries in general. There is no evidence that stretching is effective as an isolated intervention. It's actually that has been tried a lot and it doesn't come up as effective. It doesn't mean that there might be specific injuries where it could be relevant, but we saw also in relation to hamstring injuries and from the trials in Norway is that they also had a group with stretching and they compared it to the Nordic hamstring, and then there was a combination, and definitely the stretching alone was inferior to the strengthening group. Okay. So and again, if you think about a hamstring strain injury related to football, it's usually sprint related. So again, it's not related to having maximum flexibility as well. Again, it's more about being able to withstand internal forces. Exactly. So I would say it makes sense that stretching is not that relevant for a football player in relation to sprint type injury.
Did you say that sprinters actually are worse off if they do static stretching?
There are some studies showing that it actually decreases performance.
So it actually decreases performance. It doesn't increase injury. Because I was imagining you're doing like these micro tears or something, and maybe it increased your injury, but it actually makes you slower.
Yeah, there's some indications of that, and you can speculate whether maybe you're taking some of the stiffness out, maybe you're shortly, or maybe could be an explanation. I'm not a physiologist, so I'm referring to the work by others here.
The old series elastic component or something.
Exactly, but it's definitely interesting that and again, if you look at, it's interesting also the experience part. If you look at sprinters before they start their sprint, you see them jumping up and down, hitting their muscles and their head, and it's all about sort of. It looks more like it's more about neural activation. You have to sort of jam up the volume, so to speak. It's not about being more flexible before you go into the sprint.
Yeah, I actually heard the Australian. So we live in South Bank here in Melbourne. Right behind us is Australian Ballet. I actually heard they'd stopped doing stretching, which surprised me. Static stretching. They were having more.
Yeah. That's Susan Mays. I know her. That's a really good colleague of mine. I used to work in the ballet as well. I think the main point that Susan makes, and I think is really, really interesting, is that there you have so with ballet dancers, and you will see this with people who are in sports or performance arts, where they have to use flexibility, and where they are also selected based on their flexibility. So I mean, if you don't have natural flexibility, you will never be a ballet dancer or a good gymnast. They excel in doing all sorts of stretching and flexibility exercises, and I think they definitely probably need to have to work on that, and they do that in their performance as well. So I think a part of the preparation for sure is doing movements where you include a lot of flexibility. I think what Susan have stopped with her dancers is that they do again passive stretching, because again she's trying to, again, they're still jumping, landing, all this stuff. They still have to be able to dissipate forces. So she's changed the focus on that instead of having them sitting doing extra stretching. And that's also what I saw when I worked in the ballet, is that if they have extra time and if they go to the gym, they will spend most of their time doing flexibility stretching stuff. Whereas in relation to probably protect their muscle, tendons, and joints more, they would benefit from doing more active exercises with and building stability, capacity with the muscles around their joints and in relation to the muscle tendon tissues. So I think that's her main. She's been really good, because I think that's very, very difficult to change in a culture like that. So big hats off to her for actually promoting a total opposite approach than what you would see in these environments normally.
And that's evidence-based, I guess, based on what's been found, or is it more experience?
To a degree, I would say is that the evidence is there for injury prevention. Again, that's from other sports. I would say the evidence base in relation to dancers and gymnasts, for instance, we have a project with gymnasts at the moment, is very low. So again, you have to extrapolate from other sports. So you have to be a little bit careful. I think we need more evidence definitely in relation to these athletes. And I know Susan has some data on her dancers, but it's very, very difficult to get this at the RCT level 1.
Yes.
But there is definitely a theoretical rationale and evidence from other athletes suggesting that stretching alone would not really help you reduce injuries.
Okay. All right. So what about prehabilitation? So we've talked a bit about rehabilitation.
Yeah. So I think this is an interesting thing, and I have to. This is something where I work with a close colleague of mine, Thomas Bandholm, and he's been driving this prehabilitation for a few years. And the idea of prehabilitation is that it's very much related to surgery. Mm-hmm. So it basically is that the idea is that the better you go into surgery, the better you leave surgery. So you can sort of build your capacity before you go in and have surgery, and that will help you with an improved outcome after surgery.
Which is like heart patients, yeah? You get them to do, exactly.
Yes.
Mm-hmm.
And so the concept of this is very intriguing and very exciting and makes a lot of sense. The thing is, and so Thomas has been driving a lot of studies, and I've been part of these studies, is that the thing is that the evidence is actually not that good. So if you are having major, and now we're talking musculoskeletal problems, I'm not talking about other types of problems and diseases, but in musculoskeletal injuries, so total knee replacements, for instance, arthroscopy, for instance, the evidence is not that compelling, and it means that so we put out a clinical commentary as well that's not published yet, but it's sort of it's out there as a preprint. But for us, I think the idea of doing exercise before you go into surgery, or before you are evaluated for maybe having surgery or not, is very, very relevant. But it doesn't look as it, and this is probably relates to the trauma that you're getting from the surgery. So when they're installing a new knee, that's pretty aggressive surgery, and you have lots of inflammation, knee swelling. So you're actually traumatizing the knee in a controlled way. The spontaneous recovery of that, the effect size on the spontaneous recovery of your surgery is much larger, we think, than you are actually promoting now an exercise before you're actually getting the trauma from the surgery. So I think, so it sort of blunts the exercises. Exactly. And so it's very, very difficult to show actually that it transcends into a clinical response afterwards. So then you could argue, but so does that mean that there's no point in doing these kind of exercises before surgery? And this is our point that we're trying to make, is that we think it's probably better to talk about pre-evaluative exercises. So you're doing exercises with these patients. They come in, they have knee or hip OA or whatever, and you're starting them off with an exercise intervention anyway, to try and see if they could maybe avoid surgery. And that's what we did here in Copenhagen. And Thomas did a really nice study here, a PhD student called Rasmus Husted. And what we saw was that when we did this pre-evaluation exercise, so to speak, where they just did one exercise for quadriceps with an elastic band, simple strength exercise, almost your 3 times 10, and then we looked at the dose of that. We couldn't see that there was like a dosage response relationship, first of all. So it looks like just doing it twice a week was just as good as doing it more. That was one thing. But the interesting thing was that you could induce some benefits of the exercise. But the interesting thing was that if we then asked patients after doing this exercise, are you still interested in having surgery? 2/3 were actually wanted to postpone surgery.
Wow.
So
lot.
so again, that doesn't mean that we have cured their OA at all. But it gives patients an idea of something. I think that they can actually self-manage their condition. That there are things they can do that actually help them improve their current condition. And it makes
what's the OA? Sorry, arthritis.
Osteoarthritis. So these are patients with osteoarthritis who are candidates for getting a.
And we know exercise is really good for arthritis, right? So
so and exercise is good for many things. Also, I mean, metabolic health very important. So the whole idea is probably not so. We think that you should shift the focus from prehabilitation to more to give all patients the benefit of the doubt and say, yes, you are a candidate for surgery, but maybe we can avoid it or we can postpone it. And then, of course, some would still need it.
Trouble is the orthopedic, I'm just sort of joking, the orthopedic surgeons won't want to send them to you then. They'll lose 2/3 of their patients.
Yeah. At least in the short run, we can see that they will be losing some patients. But we actually worked, there was an orthopedic surgeon in the study as well. And they're good because I mean, again, you realize that if you're getting a total knee replacement or total hip replacement, I mean, you can never unreplace or untreat that. So that's sort of it's a good intervention. It works. It has, again, also a good effect size, but it's also sort of, I mean, it's not something you should just install in everyone just because they have knee pain.
So these people that did the prehabilitation, is it 2/3 of them didn't go ahead with the operation at all, or they just put it off? Or
so again, remember, this is just like a short-term follow-up within a year. So again, what we are following them now to see what happens. But there are other studies showing similar trends. Is that a lot of people actually postpone or their surgery or make.
That's great.
So the devil's advocate and the surgeons will say, they will be back, but they will. Let's see. So that's the interesting part. But still, even if you postpone it maybe 5 and 10 years, and they have just a good as effect, then it might be relevant still.
Right. So what about rehabilitation? I often wonder. I'm not sure what you have in mind to talk about there, but I often wonder how quickly. Nowadays it's so quick. Often that after surgery, for example, I couldn't believe I managed to break my neck of femur in a bicycle crash. Just not much fun, especially when they didn't diagnose it. They said, just gave me some crutches and said, off you go. But I could not move my leg. Anyway, the day after the surgery with plate and pins and things, they had me doing squats. I just couldn't believe it. I was just like, I feel like I fainted from the pain. It was just really bad. So it's interesting how quickly they do things now. Is that I guess that's evidence-based, is it? The quicker the better, or?
I think there are two things that has changed a lot, and I think definitely the time you spend in hospital or the time you spend sort of lying down we are trying to minimize that. So we're talking about enhanced recovery, and in the old days you would be in hospital if you had your knee replaced for weeks, and you would be lying a lot in bed and so forth. And now they actually they can walk home the same day many times, or they stay for less than a day, and this has many health benefits that are not which are not related to the knee alone. Also, it's actually quite dangerous to be in a hospital for too long.
Golden staph. I managed to get golden staph there.
Exactly. So the enhanced recovery is definitely evidence-based in terms of benefits for the patients in general and for general health. In relation to your, let's say, your knee or your hip, you could probably, it's definitely you want to activate and load as soon as possible. The pendulum might sometimes swing a little bit to that. I think physios now sometimes or can also be too aggressive. I think the whole idea is to mobilize people and to get them active and to activate their muscles, and it's not necessarily to do hard strength training on day 2. That's not the idea. But so I think that's definitely where the evidence is.
To clarify, when I say squats, it was just air squat. Just my body weight. Didn't have this massive weight.
No. But so that would qualify as some kind of mobilization. And that makes a lot of sense. But even if you're able to walk or walk with an aid as well, it's just to get people definitely just get people up, not lying down, so get them up, get them walking, get them, in your case, squatting a little bit, and then you, of course, you have to provide the assistance that they need, because it's not, maybe they can't fully weight bear as well. So you still, this is where you can again use equipment where you maybe, like with your hip, you can maybe train your quadriceps over the knee very, very early, just to activate a big important muscle group. So
yeah, so is there any other stuff with rehabilitation before we move on? How do you?
Yeah, I think one of the things that we're I mean, our research at the moment is definitely looking a lot on how the rehabilitation approach in general. We talk a lot about, and this is coming from the physio side of it, we always talk a lot about that treatment has to be individualized. And that's a very, again, I think it's an easy sell, because of course it would be great if I could tailor my exercise or my treatment to each individual and know that I'm now giving the best treatment to the right person. But the reality of that is that that's probably from an evidence-based perspective very, very difficult. And when we are doing RCTs, and we're doing RCTs from our department, we're always looking usually at one component of rehabilitation. So we want to compare it to, let's say, usual care. So, and then we add this component. Should we add this type of exercise? That could be heavy strength training. Should we add heavy strength training, for instance, to the care we are providing at the moment? And we have an example would be, we have patients with subacromial pain. So, impingement in the shoulder is quite a common condition. And we did a large RCT where we were asking, can we improve usual care of that by actually just increasing the volume of exercise in one group, and then the other group would just do what they would usually do, which also includes exercise. So a basic, easy question of, is doing more, would that be more beneficial? And what we did was we provided the group where we wanted to have a high volume, we provided them with elastic bands, and we actually had like a sensor on the elastic band, so we could monitor how much they actually did. And then we tried to actually increase the volume by a factor 4, so they were doing 4 times more than the usual care group. That was the idea. And then two interesting things happens is that one is that it's very, very difficult to actually get people to increase their volume on top of usual care. So we were able to sort of double the dose, but not by a factor 4. But what also happened was that when they increased the dose with the elastic band, what they did was they actually decreased some of the other stuff they were doing. So it seems like with these patients, there might be like a ceiling to what they can actually do during a week. And especially people like us who loves exercise, it's not difficult for us to maybe set aside exercise every day. We enjoy it, we love it, but a lot of patients don't enjoy it at all. So what happened in this RCT was that we could not actually show that trying to increase the volume of exercise was beneficial for these patients. They were not better than what the usual care group was. And so the conclusion could easily be that exercise, doing more exercise, doesn't work. But in this study, what we saw was actually that they didn't really do that much more as well. So this is the question about efficacy versus effectiveness. So with effectiveness, it relates to, maybe exercise works, but only if you do it. But also in reality, which is the trial we're interested in, maybe it works, but people don't do it. Then you actually, the conclusion is actually that it doesn't work. And then as a physiologist or people who are interested in mechanism, you say, but that's because they didn't do it. But for the real patient, it's more about, it doesn't work, yes, because I didn't do it, but that's the reality. It doesn't make sense to prescribe more exercise if it's not going to be translated into doing it. And so you could say, so what we then did with this study, we did this is Dr. Mikkel Bech Clausen from Copenhagen. Then we did a secondary analysis of this, because we thought, it's a little bit strange because there were definitely a lot of people who did a lot of exercises and also some who didn't do it. So we did do like the dosage response analysis. And we could actually see that if you do a lot of exercises and if you get ramped up and have more volume, you actually do have an effect. And then the other interesting thing was that we had this scale called the pain catastrophizer scale, where you actually it's a scale that actually looks at sort of three components. It looks on sort of whether people are sort of feel that if they move or do exercise or whatever, that might make the pain worse. They have feelings about that the pain is never going to get better, or they feel really helpless, that they can't go on with this, and they have all these thoughts about it. So that's what this scale is all about. They can sort of quantify whether you have this kind of personality or even deal with, or behavior, even if you deal with pain in that way, that you're afraid to move or afraid to, or think this is never going to get away. And what we could see is if you divide the groups into more and less of this behavior, then what was interesting was that actually those who had less of this behavior, so if you're not afraid to move, if you're not afraid to if you have more positive thoughts about that this pain probably, it's not never going away, then you would actually have then you would have effect of doing more exercises. So it might be that, and we cannot prove this in this study, but it might be that it's a very simple connection, so that when you don't, if you're sort of afraid of pain in itself, then maybe you and exercise actually promotes pain a little bit, then maybe you just stop doing your exercise. It doesn't have to be more complicated than that, but that also means that you can that the one size fits all doesn't work, because if you promote this to everyone, maybe there is a big group that doesn't really buy into actually doing the exercise because it's painful. But then there could be a smaller group. So, and this is where what we call stratified care. There might be a group who are willing to do more exercise and who's not afraid of the pain and who doesn't have a lot of negative thoughts about it. They might have a perfectly fine effect of doing more exercises. So this is an example of where you could say that the one size fits all doesn't work, but maybe the exercise has to be more stratified into different subgroups of patients based on their how much pain catastrophizations they show.
This reminds me, I guess it's slightly different, but you know, sometimes it's like, oh, I push through the pain, that's fine. You know, I remember I've asked physiotherapists and sports medicine doctors this before, like, you know, if I've got an injury and I'm doing what I'm meant to be doing and it's hurting, do you push through it, or like, you know, where do you draw the line on that? And I guess that's another individual thing, right? Like,
I think that's a good example, because I think it might be that it's actually very individual how that some people are totally fine with that. They're used to pain, or they don't have a lot of negative thoughts about. They know, they may have an experience also that this will go away in time or whatever. And then you can have the complete opposite, who are who if you give them something that they feel is actually provoking their problem, they get completely sort of pacified by that, and they stop doing it.
That's the thing, I guess. Sometimes you don't know. You start downing the physio. You know, you think, hang on, this is hurting more. Is it good to keep doing it, or should I stop doing it, or you know? So
and I think that's also where we're going. Is we need to have more options. It's not enough always say, but you have to do the exercise, or you have to do more of the exercises. It might be that you have to consider different options. It might be that you need to do exercises that are not specifically targeting the pain all the time. Maybe you have to sort of train around the problem a little bit. There are different things we need to look into now to I think get better adherence or compliance to the intervention.
Cool. Now, is there evidence that is there an evidence base that doing good rehab reduces the chance of re-injury? Has that been shown? You know. So I guess the biggest indicator of re-injury is injury itself, sort of thing.
There is evidence that this goes back to sports injury prevention mostly, because re-injury is usually a term we see there.
Yes.
But there are definitely some evidence from RCTs as well. There is a study from Sweden, from Martin Haglund, where they also, you can always discuss whether it was good versus bad rehabilitation, but it was definitely they were putting them through a longer program. So instead of putting people very, very fast back, they had to do more exercises. They had different milestones that they had to reach. And essentially what that did was that they kept them for longer as well. So whether it was the actual meeting the milestone or whether it was the time frame that, of course, were longer, is we can't say. But the interesting thing from this RCT from Sweden was that definitely you would reduce re-injuries by introducing these milestones, this milestone approach, where you actually trying in a more progressive way to prepare people for going back. Whereas what would usually happen, and this was why this study was so people just go as soon as they have no pain, they will try to go back, and that's a very usually not a very good idea.
Hey, can I ask you one that you're probably sick of? I don't know, been asked. The old rest ice compression elevation, so RICE, yeah. Is there good evidence for that? I guess the main one is ice. Like, is there evidence for ice? Or I guess if you've got time to talk about rest, does it work? Ice, does it work? Pressure, does it work?
No, I mean, no. I think definitely the ice part is I would say the evidence for it, or the rationale for providing ice is mainly related to reducing pain. And I would argue that often it can actually be very uncomfortable to put ice on an acute injury. So there are other things you can do acutely that are just as effective on trying to reduce pain, for instance, with an injury. I think definitely the rest, of course, getting away from the actual accident, and also maybe compression part, having your leg high up, seems reasonable, but it's not. These interventions are not that evidence-based. So it's not, and there's actually there's debates also whether I mean, there's even a debate whether you should promote heat or cold also in the sort of in the subacute phase,
alternating and all that.
What promotes a better healing response, and so forth. I would say that I don't use ice a lot or promote ice a lot anymore, also because you can have this ischemic pain, and it's difficult often for athletes to control. So I wouldn't. It's not something that I think is a very important thing.
That's interesting, because I was always thinking the rest ice compression elevation was to try and limit the inflammation. That you'd get less swelling, and then you go, hang on a minute, inflammation. This is something I spoke about with Abigail Mackey. The inflammation is a normal response. So do you actually want to limit that? And then taking anti-inflammatories, is that actually a good thing or not? So I'd be interested in your thoughts on that.
No, it's a very relevant discussion, and also she's done it on anti-inflammatories, and they get a little bit of a mixed. They have mixed results, so they both have that it's not good for the inflammatory process, but there's also some evidence suggesting the opposite. And so it's at the moment, I think it's with, especially after surgery here, they still use anti-inflammatories, and they use painkillers and try to control the inflammation after surgery. Whether that's a bad thing as well is we don't really know. But
it's interesting, isn't it? Because the body does it for a reason, I guess. I think she was saying it might come down to the timing. So if you kind of want to have your initial inflammation, and then maybe if the body overdoes it, then you do your anti-inflammatories. You know what I mean?
It could certainly be something like that. I think that definitely you also need to control if you can control the painful stimuli in the beginning, you definitely want to do that. So this is also where ice can come in. If ice does reduce your pain, I think it's definitely relevant but there's many ways that you can reduce injury with different or pain, sorry, with different modalities that are other than ice as well.
Actually, I wonder if I can ask you a question from Twitter here. Mark asked, is it possible to say which combination of variables of exercise, be it duration, intensity, frequency, modality? I think this is probably a hard question. Poses the greatest risk of overuse injury or the greatest benefit in rehabilitation?
I think for the what poses the greatest risk, I think is very, very difficult with these variables. I wouldn't, I mean, injuries are related to exposure and probably also very specific exposure. So what I can say about it is that, again, if we use, so football is where we've done the most research, is that the highest risk factor for, or the biggest risk factor for getting any, let's say, most injuries is actually match play. So there is something in relation to intensity. Definitely, there is. That's definitely the highest related to the highest risk. So a lot of exposure with high intensity, definitely a high risk, and that's probably not so surprising. But if you compare it to training, you would see even in a hamstring injuries, it can be up to 15 times more higher risk with match compared to training. So I think that you definitely in how you plan training and competition, there was definitely from those data, it would definitely seem reasonable that that's a very, very important variable. There's not a lot of good studies on that at RCT level because it's so difficult to get.
Yeah, it'd be hard to control.
Yeah. So I guess if I could frame it like that, I would definitely say that that's a high intensity sport or whatever is definitely a high risk factor and something you need to, in some ways, try to control the dosage. And we know also from football at the elite level that if you have a program schedule where you have a high match congestion, that the injury risk goes up as well.
Right.
So it's definitely something about how you plan your training and your match, and that's very, very difficult for an elite athlete because and the fatigue could definitely play an important factor. It's not something that comes out in studies a lot, but again, it's also bloody hard to research.
Right. So what about?
So that was the first part. I would say for the second part was in relation to rehabilitation. What variables? I think there you. So we talked a little bit about volume. So definitely, so exercise volume, I think, is probably a big one. With time under tension for certain tissues might be relevant. And again, I think that relates to your problem. So if you are, that was what we couldn't show, for instance, for people with knee osteoarthritis, we couldn't show that there was actually a dosage response relationship to how much exercise you do and whether you get stronger or get a better result or not. But if you then look at, I think in prevention and in healthy people who don't have an injury, it looks like there's definitely a dose response relationship in that the more you do, the stronger you get, and maybe also the more protective it is. And this is where we need more evidence to, again, it would be nice to know, but then how much is enough or how little can we get away with? We don't know that yet, so that's an important question. But I would definitely say volume it could be related to especially more healthy individuals. And again, of course, there's a ceiling. So we also know from strength training that doing one session a week is probably not enough. You need to do maybe 2, 3, or 4 sessions, and you need to go to failure. That's probably the most important thing. Then you can probably get away with doing less sets if you just make sure to go to failure, for instance, stuff like that.
Yep. Right. So what about when we think about physiotherapy? Up to now, we've been thinking more about just I don't know, using your own body. But what about the adjunct modalities that physiotherapists have? Yes, various bits and pieces.
So I think that's also the challenge there is that very often we look at one intervention at a time. And I think that all these adjunct treatments is probably being criticized a little bit for not working often. And what we have to be aware of is that they are adjunct treatments. They are not the main treatment.
Standalone. Okay.
Yeah. So I would definitely say that very often it's the main ingredients that that I, as a physiotherapist, promote. So again, so that's why I don't like it to be called physiotherapy, but that is related to exercise-based strategies, and also try to monitor load. So those two together is probably sort of the main ingredients. Definitely different modalities that do seem to have an effect, for instance, on pain. So we talked a little bit about, you talked about the rise, but electrotherapy actually, transcutaneous electrical neural stimulation is actually quite effective on pain, especially while it's on, and also has been compared also to, if you use that kind of modality, can you then decrease opioid use, for instance? That could be after surgery, and it looks definitely like that some of these modalities can actually decrease the use of other medicine. So
can you tell us what that is?
So that's basically that's the TENS, and it's basically an electric device with a specific frequency. You have low and high frequency, and basically it's current stimulating your nerve endings and providing both like a gate control mechanism, but also actually stimulating the body's own opioid response.
Is that the one where you have like an electrode? If you're doing your quads, you have one near your knee and one at your hip, and it's kind of midway is where it's.
So this is the interesting part about, I would say, these apparatus is that you can use it for pain, where you have a certain threshold and a certain hertz where you use it for that, but you can also use it for activating your muscles, where you have other thresholds and it actually makes your muscle contract. So basically it can move your leg. And that's more what we call neuromuscular stimulation. And that's also, again, one of the things that has been shown to be effective, actually. So especially post-surgically, to activate your muscles in the beginning, you have inhibition again from an inflammatory response from swelling in the joint. We know this inhibits muscle activation. So here, within, I would say, the first initial 6 weeks, actually activating and your muscles with stimulating electrically actually increases muscle strength in people going through, that could be ACL surgery. Also, if you get a new, if you have a total knee replacement, stuff like that, you can actually stimulate your muscle strength by adding this to of course, normal mobilization and strength training as well.
Okay.
It's not as soon as you can do voluntary activation with no problem, normal strength training, it's less relevant to do this. And the current also, it actually, when it stimulates, it's sort of, I don't know if you've ever seen it or tried it yourself, it almost looks like it lifts up the muscle a little bit. Mm-hmm. So it's actually very superficial that it addresses the motor points. So it's not like a deep stimulation, but it definitely does help people, and people also have to be active and activate together with the apparatus. So it might be that it's basically just an aid that helps people activate better. It's not necessarily the apparatus alone that helps.
And you're saying that reduces pain, but also causes endorphin increases? Blood?
Yeah. It stimulates the whole the own opioid sort of system in the body, and that's interesting because you can actually make people sort of a little bit resistant. So you have to be a little bit. There are some studies suggesting that if you use it in a specific threshold and the same threshold all the time, that you're actually sort of diminishing that your body's own ability to produce opioids, for instance. So again, you also have to consider doing different thresholds, and probably also seem to be the evidence that you have to sort of increase the volume as high as you can actually tolerate. So and maybe also change the volume from time to time so that the body doesn't accommodate or adapt to the situation. And then again, I don't think this is something you should just do all year in and out. Again, it works really well post-surgical, both for activation but also for pain reduction. It could replace medicine to a certain degree. Not that it should replace it totally, but it could replace it certainly. So there is some evidence for that, and I think we need more research in that area.
And then it's only until you can do your own contractions.
I think as soon as you can do your own contraction completely and do sort of proper strength training, I think it's not worth. Then it's much better to just do that.
So are there other machines that work, or machines that people use that don't work?
Yeah. I mean, I think ultrasound was the big one when you've probably seen that one. That's probably the machine that has probably the least evidence. And we also used to laugh about that machine. It was always in the room, and sometimes we forgot to turn it on, and people felt a lot better. So again, that just relates back to the contextual factors and the placebo effect of the treatment. But then some of the apparatus that are mentioned that I would sometimes also could include is you have shockwave is one. And shockwave does have some evidence, especially in relation to calcifications. It was actually also developed for treating calcifications. And so in the shoulder, there is some evidence for that. A little bit of evidence in relation to tendon problems. The mechanism is a little bit interesting because there's some suggestions that is actually related to desensitizing the nerve endings as well. So so it might not be that, again, it's not necessarily a structural or mechanical intervention per se. It might again relate to the nervous system, but there is some evidence for that. And even massage, if you in relation to groin problems, we've seen that if you include a massage on top of exercise, it looks like some of the players actually return quicker than if you're just doing the exercise. So that's the idea of an add-on, is maybe that you can reduce the days, or maybe get people back quicker.
Okay, so there is evidence for massage. I was wondering about that.
I mean, this is not high-level evidence. I'm just saying that it might be that if you use it in conjunction with exercise, there might be that it could have an effect on something like return to play. Whereas if you just use massage as a standalone treatment, the effect is very, very short-lived. It's within hours. You definitely have a pain decreasing effect, but it's usually not lasting, and that's also why it's very rare that you will see studies if they're placebo controlled that have an effect in chronic patients over a long period of time with these passive treatments.
Well, it's interesting we've touched on how placebo can be as good as nothing sometimes, because Mark again had a question on Twitter. Please elaborate on the clinical implications of some of the results suggesting that sham surgeries are as effective as physiotherapy for some diseases. Also, please elaborate on the data suggesting that intra-articular saline injections are as effective as physiotherapy. Yeah.
So so Mark is a well-informed
he is actually
researcher. Yeah. And is following, I think, some of the research also related to, I would say, physical therapists. So some of the research that has been done by physical therapists and together with also doctors. And I think we can take the study he refers to is one where they're comparing. It's a study from Copenhagen, a brilliant study where they're comparing exercise and education, which is almost like a trademark intervention called GLAD, which is also in Australia, and they are comparing it to saline injections. So they get 4 saline injections over the same period of time, and it's an interesting study. I think people should read it. The interesting thing is that one treatment is not superior to the other here. So But I would also say that both of these treatments for people with osteoarthritis, knee osteoarthritis, have very small effect sizes. So basically what the study shows is that they're not, one is not better than the other, or and then actually I would say very almost the effect is very small from both of them. I think that's a very important take home as well. And that's also, I think, when we look at exercise alone for osteoarthritis, it does have some effect, but the main effect we see is when we compare it to no intervention. So this is also what he's asking about. Is that effect then specific? Is it actually related to some structural component that exercise is promoting in the knee joint or in the muscle? Or is it basically just spontaneous recovery, regression to the mean, or the fact that you are now seeing a physio? And I think that the jury is still out there. I think definitely it's worth going to see a physio with your osteoarthritis problem, but we cannot say whether the treatment that is provided by the physio is that actually coming from promoting a series of specific and good exercises, or is it the whole process that actually helps at the minute? So I think it's a relevant question. The clinical implications of it is that I would at the moment not, and that's not the purpose of the study, I would not promote and tell them to go and get saline injections. I would send them to a physiotherapist still, or ask them to do exercises. It could also be, it doesn't have to be a physiotherapist, but I would get them on some kind of exercise-based approach still. But then again, it also very, very important for these patients, if they can lose weight, might be just as important, even more important. And be physically active is extremely important also in relation to their metabolic health and their general health. So I would say that's probably the implication, is exercise is not necessarily at the moment explaining why you can improve the condition of people with OA. I hope that answers some of that question.
It does. Well, the other thing that sort of fits with that is, you know how if you scan people, so if you're screening, you know, it's a bit of a thing nowadays. Some people want to get screened for everything, do like a whole body MRI, but you're always going to find something that probably didn't bother them before. So, and I've heard the same, if you do an MRI of a knee or your back, a lot of people you're going to find something there, but even though they're not in pain, and other people are going to be in pain and they can't even see it there. So it sort of fits maybe with what you were saying, is, you know, no wonder then if you do an operation, it's not going to do anything, or you can do saline in it, you know what I mean?
And this definitely relates to this care model again, where you, and this is also why I think you need to start out with the least aggressive treatment and approach you can do before you start going into, and that might be the one size fits all, and that often relates, and exercise and load is often in there as a very important ingredient, whether it's sports injury prevention or actually rehabilitation. And then from there, for those patients where this is not enough, or it doesn't really help their problem, then you have to consider a more stratified approach. Is there anything else, or an add-on or an adjunct? Is there anything else we can promote that might help their problem? So it's more, we call this step-based care. It's actually, so it's not that it's not that individualized as is. I cannot tell you what treatment you need, but I can in a logical stepwise order go from least aggressive to maybe more and more invasive, and then you can consider whether is surgery then the last option. And for some conditions, I would definitely say joint replacement is an effective intervention. For arthroscopy, and this is also what he refers to in his question, it's more debatable. Is arthroscopy actually better than doing nothing? Or actually, if people think they had a arthroscopy, can you actually beat placebo there? So that's a little bit more difficult sometimes to argue. So again, but I think the main point is that you don't start off with surgery, because that's the most aggressive intervention you can actually find.
And then the other thing is, you could have, you know, like I was sort of saying, you could have a bad back, and you go to have a scan and they go, oh, I can see something there, but that may not actually be what's causing your bad back. You know, that thing they're seeing may not actually be a problem. And
that is exactly the stratified and the precision idea, is that you can on a scan actually see something that makes this patient unique, and in relation to a specific treatment. And you are actually making that point, is that we can't do that at the moment. And we can maybe end on this note, is that we're trying now with some of the research we do, is we're trying to come up with prediction models where you have a lot of variables in to try and understand who actually benefits from, let's say, surgery and who does not. And you can do the same for the exercise intervention, who actually benefits from it or not. And it's a much more complex issue. It's much more, you need a much more multivariate approach. And at the moment, and what we've seen, there's lots of research now with machine learning. The main problem with a lot of these approaches is that there are a lot of prediction studies coming out where they actually are not validating their model on a sort of an external cohort afterwards. So they are basically overfitting their model on the cohort that they are developing the model upon. And then they say, oh, but this predicts this and this and this. But basically what you have to do is you have to come up with a model that are actually able to help the next patient that walks in through the door to see if they would fit into a more stratified approach, or even a precision approach where you say, okay, but with this patient, we know that this treatment works well. And we are not anywhere near that with most of our...
Yeah, I could talk about this stuff forever, as you can probably tell. But what about some takeaway messages from our chat today that you'd like people to get? Yeah.
No, I think I think if we see it from a physiotherapist perspective and the value that a physiotherapist can add, I think definitely in injury prevention, I think we have a huge role to play, and there is good evidence that we can include different strategies that are exercise-based that actually can reduce injuries a lot. The main evidence here is from football, and we have to be careful not to extrapolate to all other sports. So like cycling, I would definitely not extrapolate this to. And then we can, I think, in relation to the efficacy of some of our interventions in rehabilitation, I think we have to be very much aware as a doctor or physiotherapist that a lot of the effect that we see with patients, and even in studies as well, is a lot of that is contextual factors. They are not necessarily specific effects of the interventions that we promote. That's not a problem. We just have to be aware of that. And I think the main idea is still to help the patients as best as we can. And we probably go from a more sort of general approach, and then in order to try and help as much as we can, we should definitely start there, but then we can try to stratify based on evidence or data we have, or even experience, and go from least aggressive to the most aggressive, and not start with intervention that might have serious side effects or adverse events related to them. And then I think, well, the last point could be that I think that prehabilitation might be drowning sometimes in if the big intervention if there's big surgical intervention. That doesn't mean that it's not relevant to do exercises before you go into being evaluated, but it might have a different purpose than actually trying to fit the better in, better out mantra. So I think that's probably some of the main takeaways. Perfect. And then, of course, the adjunct treatments, I think they're getting a bad rep, but I think in clinical practice, they're definitely worth considering sometimes to add things in trying to maybe control pain, for instance. It could be in relation to reduce medicine, also because some of this medicine has adverse events and other issues related to it that we want to reduce. Opioid use being one of the really bad ones. Like in the States, maybe also in Australia, we have this opioid crisis where people are getting addicted to a very strong painkiller. And I think there are definitely some of the electrotherapy, we do have some evidence, at least in the acute phase, but maybe also as an adjunct to bringing people back with even less pain or even faster back.
Great. All right. Well, I've really enjoyed this. Obviously, I think it's close to 2 hours somehow. So, but I'm not going to cut any of it out. I found it really interesting. So good on you, mate. Thank you very much for coming.
So
on.
at least we put people to sleep, all right?
No. And maybe I'll see you in Copenhagen riding a bike.
Oh, definitely. We go for a beer or something. That'll be nice.
Okay. Good on you, mate. Okay. See you. Bye-bye.
Thank you. Bye.
Thanks. I hope you enjoyed this podcast. Please like, subscribe, pass it on to your friends and colleagues. Check out the other podcasts. Thanks again.